Open enrollment for the Affordable Care Act health insurance plans for 2026 begins on November 1st, 2025. This period generally runs until January 15th of 2026, though specific state-based exchanges may have different dates, so it's important to check local deadlines and that you should be aware that some states may have different enrollment periods. And here to talk with us about all of that and then some is Jae Oh, author of Maximize Your Medicare. Hey, welcome.
Here we go again, Bob. How are
Here
you?
we go
Thank you for
again.
having
Way
me.
to be.
Well, you rightly point out you gave away a lot of my secrets already, which is that the national rules are that the open enrollment period begins on November 1st. You can already preview plans depending on when you watch this video. It is already available on healthcare.gov. In order to get the advanced premium tax credit, which is kind of known as the subsidy by many, it is still intact despite all of the political news and headlines that you may read here. The fact is that you will still qualify if you meet certain criteria. There's something called the federal poverty level. If you do not exceed 150% of that, which will be based on your household size, for example, and your age, then the APTC will still exist. Underneath the surface, it gets more complicated because the number of plans has changed. There's still a lot, meaning that I looked the other day for Atlanta, Georgia, Tampa, well over 100 different plans. Now the work begins, which is choosing the plan where the networks work for you, choosing a plan that is appropriate for your budget and your health situation. A very complicated selection process coming up.
Yeah. So maybe start with this notion of which plan. You've got bronze, silver, gold, a premium, bronze being the least expensive and platinum being the most expensive. What do folks need to know about these plans? And then I guess in terms of the advanced premium tax credit, it's a fixed dollar amount. So if you do choose the platinum, it's still expensive. But if you choose the bronze, maybe it'll be less expensive with the APTC.
For sure. These different tiers, the metals, are basically ways that the CMS has grouped the plans where you're trying to meet a certain percent of your total healthcare cost amounts. Now, like you rightly pointed out there, it starts with bronze and it goes up to platinum. That said, they're guidelines, and I urge caution to not just blindly choose platinum because you think it's the best or silver for a particular reason because your friend chose a silver. The fact is, those are secondary compared to the quality of networks for you and your location. That these are the drivers, meaning that the last thing I want is one of our clients, to blindly choose a platinum plan, bring it to their doctor, and the doctor doesn't accept the plan, when that same doctor may have accepted a bronze plan, which would have cost many thousands of dollars a year less the entire time. And these are the kind of practical, everyday, common sense mistakes that actually occur all the time. People wrongly think, I have a platinum plan, it's the best, just to find out that they may have used money that wasn't needed or could have been deployed in their daily lives for other purposes based on their particular circumstance. But again, like you pointed out correctly, so you've got these tiers, they're good guidelines. There are also that if you qualify for APTC tax credit, that it is still the case that you can have better deductibles out-of-pocket maximum within certain silver plans. So it's important to have these combinations. The nuances are very, very subtle. They make a huge difference to people.
Yeah. When you talk about network types, we're talking typically about an HMO, a PPO, and then something called a EPO as well?
That's right. Very, very complicated here. So let me first say that to give you an idea on how complicated the world has become, in many locations, there's no such availability of PPO at all. So HMO, EPO, they share in common this idea that you need to have a primary care physician kind of directing traffic, a quarterback, if you will, that you need to go through a referral process that starts with the primary care physician, kind of directing traffic so that if you need follow-up care, follow-up attention from a specialist, the primary care physician has to direct. That said, the nuance of the label between EPO and HMO, for example, is probably a little bit too complicated for today, but it is certain they are certainly there. But mainly I'm focused firstly on primary care physician and then specialist. If you already know that you need a specialist, for example, let's just say you have a heart condition and you have a cardiovascular specialist, then you'll want to make sure that clearly that the specialist also belongs.
Yeah. I want to go back to something you said earlier about the advanced premium tax credit, that it will still be available for folks who are under the 150% of the federal poverty line. What is going away is the enhanced advanced premium tax credit under as of the end of the year. Is that fair to say? And that whatever guidelines were in place for the enhanced tax credit are gone or will be gone?
So we've discussed this for months, actually, but you've been good enough to allow me to talk about this, which is as it currently stands, what ends up happening is if you exceed 150% of the federal poverty level, you will see the degree of tax credits sharply decline. And it can be dramatic because the enhanced premium tax credit extended all the way to 400% of the federal poverty level, which is a strange naming convention, right? Because 400 times the federal poverty level is not poor at all. So now what you have is, however, you will see those people be particularly surprised that people that exceed, for example, $100,000 a year and up, and I'm just using a general figure, that, for example, a couple that has taken early retirement that is with making withdrawals from their 401k or IRA to help support and pay them to pay their monthly bills, they're realizing taxable income. Well, that also is taxed when you convert to your non-qualified funds, but it also has this second effect, which is to reduce your APTC. And this is the source of my concern, to try to alert people that this is coming in the absence of specific legislative action, which is absent so far.
Yeah. And then when you think about the premium rate increases, you've had a chance to look at some of them, and there's a lot of fear that some of the increases will be so dramatic that people may forego health insurance because of it. What are you seeing with rate increases at the moment?
It is not different than what I had thought. That said, what I had thought was that people would have double, triple, meaning that the amount of cash that a household couple may use, a married couple, it really hits those persons in Gen X, if you will, meaning that 50 and up. This a married couple that has to purchase health insurance for themselves and are middle class and higher, but not necessarily worth $10 million, these people are going to feel the pinch because the difference in dollar terms when you remove percents is 20,000 plus more per couple per year for all the years prior to Medicare in the absence of any direct action.
It's a bit, I guess people are in for a surprise, suffice to say then, some people.
It's why we've been trying to alert people that there's little time left, but there are still a couple of months left, meaning that people can plan around this in certain ways, being to arrange for cash flows, access to cash flows on a non-taxable basis in 2026 to try to retain as much of the advanced premium tax credit as they possibly can.
Yeah. So, Jay, KFF, one of our favorite resources around all
Sure.
things healthcare, published a piece in which they described 8 things to watch out for during this enrollment period. One of them is this notion that marketplace enrollees could have to repay more at tax time because of the way the tax credit worked. Any thoughts about the potential for that to happen?
There have been certain measures for sure to tighten the kind of adherence to the rules as existing written. So, for example, there used to be a limit. If you had underreported, or for example, if you had claimed an excess amount of advanced premium tax credit, you would have to pay them back. That number was capped in the past. That number is no longer capped, for example. In addition to that, when you claim the APTC, you will have a far tighter window to verify your income so that you can actually access the tax credit on an ongoing basis. So at the margin, what you have is tighter enforcement so that to reduce wrongdoing. And the issue is that some of that wrongdoing can be unintentional, meaning that a greater burden sits with the people, households, to make sure that they've got their I's dotted, T's crossed.
Yeah. Another thing that KFF mentions, and you sort of hinted at a little bit ago, is that enrollees may face higher monthly premium payments and then may decide to switch from a silver, gold to a bronze or catastrophic plan to keep premium payments down. But the trade-off would be a much higher deductible. So that's in store too.
Yes, that is not really a change though, Bob, meaning that this was always the case, meaning that when you have a lower premium, it is logical in most cases, in the base case, that a higher deductible, higher out-of-pocket maximum exists. For some households, the out-of-pocket maximum in particular is the key fact because some persons have a health situation where they know with a very high degree of certainty that they're going to require such extensive healthcare services that they always meet the out-of-pocket maximum. And so now it's it's a mathematic exercise to add 12 times premium plus out-of-pocket maximum to try to minimize the total number. Our clients are guided along those metrics, meaning that in the absence of a crystal ball, meaning if you don't know if you're going to get ill and you have good health, then I generally try to lean to lower premium because you have to pay that for sure with 100% certainty. That said, it can be, if you are unfortunate, that you are in for a surprise, meaning that deductibles high, out-of-pocket maximum high. As long as the risk is known, then it's okay in a very difficult situation. But certainly after the fact, it can be a surprise. That is true.
Yeah. Another issue that they raised is that currently lawfully present immigrants with incomes below 100% of the FPL who are ineligible for Medicaid because they have been in the U.S. for less than 5 years are eligible for subsidized ACA marketplace coverage.
This is going to be some amount of controversy here. Obviously, there are politics involved. The narrative is out there. What I would say is that you have to ultimately verify, however, your information, meaning that your paycheck. So while these are true, and I'm not stating that they are untrue, what I'm also saying is in practical reality, the number of people that this will actually be compared to the number of people who are going to be affected by the lack of this tax credit or the sharp reduction of the tax credit is going to be very small, meaning that you could have these unlawful people here trying to get this tax credit, but still having to provide the evidence of a lawful paycheck in order to get the tax credit. This combination of people needs to exist. So I haven't seen figures on how many that would be. What we do know is that about 20 million people get the APTC who are lawful. Almost all of them affected.
Yeah. Another point KFF brings up is this notion that consumers with lower incomes can no longer sign up year round for an ACA plan.
Deep in the weeds, I did sneak this sentence in, Bob, last year, which is that, yes, that in the autumn, it used to be that if you were lower than 150% of FPL, that in fact you had year-around enrollment rights. That option ceased to exist already now. It is not a new thing, a new feature, if you will, for 2026. That is in place today.
So something I'm unfamiliar with is the Navigator funding, which I believe is used for nonprofit and community organizations to provide help. Funding for that has been reduced, and any ill effects from that?
It will depend. on the location that, for example, navigators, as you rightly stated, the funding has already been curtailed. And I want to say the number is 90%. So it is dramatically lower. There might be community based assistance volunteers that would be able to help in this regard to try to help people understand health insurance as a whole. That is possible, but I don't think there's any question that to a population that doesn't understand insurance, much less health insurance, and then having to navigate, no pun intended, all of the crossfire that you're seeing and hearing about, then it's going to be an ongoing challenge for the population for sure.
Yeah. The last thing that KFF mentions is that some planned regulatory changes to the ACA marketplace have been temporarily blocked by a federal court, assuming that that block continues throughout the enrollment period. Perhaps no changes to enrollees for 2026, but if those court challenges should, I guess, be ruled in favor of the administration, do you foresee any changes that could impact enrollees for 2026?
I don't really think so for 2026, to be candid, meaning that by the time that all of those issues are resolved, the time has passed. The carriers candidly are going to adhere to the rules as stated when someone enrolls or applies and their application is accepted. It is not going to come from the carrier in general. That's not been my experience. Even if some type of action occurred which curtailed it going forward, to roll back, to go into a time capsule and disenroll someone forcibly seems very unlikely, to say the least.
Yeah. So as you know, I'm fond of saying that we've covered a lot of ground, and I'm fond of also saying that or asking if there's anything we missed or anything that just bears reemphasizing.
Well, this year more than ever, I think that people are seeing the fact that one of my main reasons for Jay's Corner, which is a newsletter, and all of our conversations, why I've appreciated you so much, Bob, is the fact that I realize that we talk about individual topics as if they're actually shielded away from one another. But now, right here in the news, pretty much every hour, is the fact that taxable income and your health insurance premium are linked. And that should be a warning sign. Warning sign is probably too strong a word, but there should be a signal as evidence for you, one that you can see and touch every day, which is these topics are actually directly linked to one another, meaning that to think of them separately just would be suboptimal for a household that is trying to pay bills, that is facing inflation, wants to consider their financial future.
Yeah. So true that we think of these things sometimes in silos, but they're not silos. They're interconnected and with adverse effects waiting for those who forget that.
That also, I don't want to be only a downer about it, right? Meaning that there's too much focus on the negative. The flip side is that well planned, it actually can open the door to a trajectory where early retirement is possible. Yes, that is also true.
I'm reminded as you say that the number one question I used to get before ACA existed from pre-Medicare workers who wanted to retire is, how will I ever be able to afford health insurance while in between my retirement and Medicare? And ACA came along to sort of eliminate that as one of the most commonly asked questions I ever got.
It takes work. It does take work. That said, properly planned, possible. Yes, that's right.